Awesome. Welcome, everyone. Today's discussion focuses on a critical issue, advocating for Black maternal health. There are many paths to advocacy in women's health, and through this conversation, I hope we'll discover various approaches that ignite a fire within you to fight for better outcomes for our Black moms specifically. My name is Dr. Danielle. I'm an OBGYN in the Air Force, as well as the founder of Honey, which is a postpartum digital health platform that comprehensively supports postpartum moms and dads through coaching, courses, and community, as well as through continuous depression screening and an internal mental health referral when they need it most. Today with me, I have some incredible panelists that I will have introduce themselves. But before I open the floor for their introductions, I do want to highlight that Dr. Cohen, the director for the CDC, will come into this meeting and highlight the Hear Her campaign. So without further ado, we can get started with our introductions. We can get started with Dr. Bonaparte, then Dr. Canty, and then Dr. Meadows. As the conversation is rolling out, when I start asking them questions, if you have a question for any of us, please drop it in the Q&A tool, and I'll be sure to review them and pose them after we end our discussion. Dr. Bonaparte, I'll let you go first.
Good morning, everybody, wherever you are in the world as you're listening to us. My name is Dr. Alicia Bonaparte. I'm a professor of sociology and trained as a medical sociologist here at Pitzer College, which is a member of the Claremont Colleges. My areas of research tend to fall around the lens of maternal health, inequalities and inequities, and also the history of Black midwives, particularly grandmother midwives, are also known as granny midwives in the United States. I'm very excited to be here with you all today.
Okay, good morning, everyone. My name is Lucinda Canty. I'm an associate professor at UMass Amherst, the Elaine Mayer College of Nursing. I'm also a nurse midwife. I'll be celebrating 30 years of midwifery next month. I'm adding a year on next year. I'm a qualitative researcher, Black feminist. My work really works to uplift the voices of Black women. I just feel like our experiences, our histories are so important to even addressing issues that we see today. And I love being engaged in the community, and I'll talk about my work with Lucinda's House, but just also history is so important, history of nursing, midwifery, and also what I like to incorporate into my presentations and my work is storytelling in the arts. And I'll talk about that as well. Thank you for having me.
Good morning, everyone. My name is Audra Meadows. I am an obstetrician gynecologist and professor of OBGYN at the University of California in San Diego. The work that I do is to also lead initiatives to address maternal health, particularly maternal health inequities and disparities. I call myself a birth optimizer. So many of my projects look at both the outpatient space and academic obstetrics to ensure that we have care that meets the needs of all birthing individuals. And I also lead state-based initiatives, particularly the PINQUIN, our state perinatal quality collaborative in the state of Massachusetts, the PINQUIN Maternal Equity Bundle. And that work looks to addressing and putting in place safety bundles so that hospital teams can support moms and babies with addressing maternal inequities, and also checklists to make sure that we're putting in place high levels of quality and safety for the most optimal birth that someone can have. I'm happy to be here as well.
Amazing. So we will get started. So I have prepared questions for each of our panelists. I will say around 10:15, we will pause with the questions that I have lined up to allow, again, Dr. Cohen to come in, explain the Hear Her campaign, and then we'll continue on with the conversation. The first question goes to Dr. Bonaparte. Dr. Bonaparte, your work and publications delve into the historical context of Black maternal health. Why is understanding this background so important in our efforts to advocate for change in the healthcare system and our approach to caring for Black women antepartum, intrapartum, and postpartum?
Thank you so much. So I have a little bit of prepared remarks, and so I feel like it would be useful to use some slides just to kind of give some context for people to follow along. So to quote from a piece that's actually co-authored by one of my lovely panelists today, Dr. Lucinda Canty, in which they say, quote, "Racism and discrimination negatively affect patient-provider communication. Yet pregnant people of color consistently report being discriminated against, disrespected, and ignored." But I think for me, as I mentioned before, I'm a historical sociologist slash medical sociologist. And so I always think it's important to start with historical context. So as I begin my remarks, I'm going to borrow a little bit from the medical ethicist by the name of Harriet Washington, and in particular her text known as Medical Apartheid, which I highly recommend, in which she explains this image that's before you. This is a painting that was created by Robert Tom. It's titled J. Marion Sims, Gynecologic Surgeon. And in this particular piece, you see a depiction that's commissioned and distributed by Park Davis Pharmaceutical House, which is what we now know as Pfizer, more than a century ago, to illustrate Betsy. Betsy is the enslaved Black woman in the middle. And in particular, one of the things that I'm hoping that you notice is that she appears to be sitting there calmly on this very small table surrounded by 3 white male physicians. Now, what's interesting, though, is that if you can't see, there is actually a couple of enslaved Black women that are peering behind this white sheet. And as Washington notes in Curiosity. However, one of the things that is important to note is that this image is vastly different from, quote, "the gruesome reality in which each surgical scene was a violent struggle between the slaves and physicians, and each woman's body was a bloody battleground." Now, I want to be clear in that noting that these surgeries were for the purpose of experimentation, not for treatment, and oftentimes they lacked any form of pain mediation, particularly because physicians at the time, and unfortunately some even today, perceive that Black people have a higher tolerance for pain. In essence, these women's cries for help and also for the experiments to stop were unheard. I want to pause here for a second and simply state that I'm not going to detail further more of the details that Washington provides in the text, because I want to avoid something that my colleague and friend, Dr. Lori Walkington, refers to as a pornographic fascination with pain. But I do want to make sure that I highlight this history to explain why current day experiences in maternal health are met with trepidation, most especially by Black birthing folks. I purposely put on the slides the names of Anarcha, Betsy, and Lucy to honor that they are the mothers of gynecology rather than Sims serving as the father of gynecology. Sims, like some of his later obstetrical compatriots, like Dr. Robert D. Lee, argued that birth and pregnancy are unnatural and dangerous, aka pathological, requiring supervision by a doctor and solely within hospitals, aka a medicalized event, and then making such arguments were couched in particular kinds of ways. One of the things that I think is also intriguing to mention here is that there was a history that happened One of the things that was really important is that this history involves taking away these beloved caretakers, in particular birth attendants known as grandmother midwives. This is a picture of a midwifery class that's taken from the Penn Center in South Carolina. The reason why I'm mentioning this is that these women were revered by both Black and white folks. And not only were they revered by these individuals, but in addition to that, they were trusted community members. However, as I mentioned before, doctors were pushing to make for sure that birth was seen as something that was medicalized, it required supervision, and also should happen within hospital settings. So the unfortunate consequence of this is that they remove the autonomy and legitimacy of these grandmother midwives, as I talk about in my research. One of the ways in which they did this is they problematized these women. They argued that these women were incompetent, and they used racism, sexism, and also the threat of interoccupational conflict as a means of saying is that these are not people that you should no longer trust. When you do these kinds of things, this shifts authoritative knowledge from people who have been steeped in this knowledge of birthing over into the medical establishment. So I wanted to make for sure I kind of highlighted that history really quickly here.
Thank you for sharing that. So how can we integrate this historical knowledge into the education of our doctors, nurses, and other healthcare professionals at both the undergraduate and graduate level? And in your opinion, can understanding this history influence how care is provided to Black families, specifically, again, antepartum, postpartum?
Mm-hmm. So I really appreciate this question too, right? Because again, you have to understand history. This slide here really quickly is I wanted to make for sure that people were aware that there's several texts that are really important. I've already mentioned medical apartheid, but also George Yancey's work and also John Hoverman's work as well. When we think about that there's this legacy of scientific racism and that it persists, then the next question becomes, how do you integrate this? The first thing that I always suggest to people is to revamp your curriculum, right? Teach medical apartheid, birthing Black mothers, medical bondage, race, gender, and the origins of American gynecology, and also include books, for example, Drawing Blood, Technology and Disease Identity in 20th Century America. I always think that it's just really important that people go back and think to themselves, what am I teaching and what am I not teaching? So this is where I start there with that point. Another thing that I think is particularly important is that we have to require students to understand the role and the history of birth justice and reproductive justice within birthing settings. One of the ways in which I see that this is extremely important is thinking about texts like Reproductive Injustice by Dr. Danny Ann Davis, and a small plug for my own book, which is in its second edition, Birthing Justice, Black Women, Pregnancy, and Childbirth. I want to pause for a quick second and mention really quickly that there's the text that I mentioned earlier by George Yancey, Black Bodies and White Gazes. He historicizes really beautifully that Black folks' bodies have been marked by a number of ways in which an upliftment of white supremacy. So when we consider, right, these kinds of things, this is the reason why I'm suggesting to go back, look at what it is that you're doing in your own curriculums, and also requiring students, particularly people who will eventually become practitioners, to know this kind of work. The other thing that I wanted to make sure that I highlighted with Black and Blue by John Hoberman is that this is a text in which he actually interviewed white physicians. And in particular, one of the things that he found is that they actually discredited that they were racist towards Black patients. So again, having this kind of history and having this kind of context is extremely important. And then the other thing that I always think is important to think about here too is to listen to Black women. For example, Dr. Rachel Burble has a project called the Black OBGYN Project. And as a matter of fact, if you go to her website, one of the things you'll notice is that they'll be uploading anti-racism curriculum very, very soon. And then the last thing is when we think about, can we make a change? Folks can and do change. We can recognize that bias can be overt, covert, unconscious, and it requires what I refer to as an unlearning praxis. So this means engaging in self-reflection and community learning with humility to develop rapport. Think about concepts like therapeutic communication, and then also thinking about patient and physician models that actually allow for a shared decision-making process. And then also you can use other measures that are currently in existence right now, like Dr. Karen A. Scott's PREMOB scale, which is located at the birthingculturalrigor.org website. This is a way you can kind of check yourself, like balances and checks to make for sure, are you doing the right thing? And then last but not least, I put in a little bit of color just to highlight some things. And that is there's a new revamped Black Birthing Bill of Rights. The second edition is forthcoming, but some of the old pieces I think are still very true when we think about communication. So things like I have the right to be listened to and heard. I have the right to have my humanity recognized and acknowledged. And I have the right to be respected and to receive respectful care.
Thank you so much for sharing. I graduated residency in 2020. I trained in South Carolina, and one of the attendings that I trained under A phrase that still haunts me to this day, without providing any context, she specifically said, and she's a white attending, I didn't think or I thought racism didn't exist. And this was, again, right after Mike Brown and a couple of other things. And so her saying that really highlighted my experience in residency, and it ignited a passion in terms of how I want to unfold the work that I do going forward in my career. So thank you for sharing. I look forward to you reading your new book, and we will press on. One second. Okay, yes. Dr. Meadows.
Thank you so much, Dr. Bonaparte, for all you discussed. This is so critical and so important. And I wanted to add to that. And so some of the work that we do with the Perinatal Quality Collaborative, maternal equity work. And so there have been some states that have been able to address maternal equity to really get at the heart of what we need to do to close gaps and outcomes. We have to talk about exactly what Dr. Bonaparte just described. And so these are conversations that we have been having across OBGYN departments now, more in the recent years, since probably about 2020, some before, definitely, but at greater rates since about 2020. And so wanted to also call attention to something that we continue to bring up in the conversations we have as we put together these bundles. So just quickly to say what a bundle is, it just as simply as a checklist of activities to address improving quality and safety. And one of the checklists of activities that we look at in our maternal equity bundle is that to discuss what is being an anti-racist, what is racism in healthcare. And that is really critical, but it's also more important to talk about it from a standpoint of ensuring that people understand the critical Black history of what we're discussing and not just Black history. I often bring this up with some of the students that I teach. Also, I teach at the University of California in San Diego, a course called Health Equity and Health System Science. And we talk about how many people in the United States have grown up, have heard about Black history, but they've only heard about Black history from the positive direction, what people have been able to achieve, which is an important conversation. When it comes to making sure that clinical care providers and those who will become providers understand critical Black history, I wanted to call attention to a paper that had also been published in September of 2023 by Dr. Kim Martin and Carrie Johnson. And it was called "You Can't Dismantle What You Don't Recognize: The Effect of Learning Critical Black History in Healthcare on Perspective Taking." So we talk about how even having these conversations, it cannot be just a one-off. It has to be a conversation that is ongoing. And when we start that conversation, we want to make sure that people understand exactly the history that Dr. Bonaparte just explained and showed, the mothers of gynecology, the understanding that there's still data that shows that people believe that pain is not, that experience of pain differs by racial groups. We've been espousing and saying to people, race is a social construct. It does not define a genetic difference and variation among individuals. And so making sure people hear that and learn that, that's still in the more recent years. I think it's really a great thing that we talked about this and that these texts exist because we use these as a basis to explain this information. We also, in our work with the maternal equity strategies, we talk a lot about communicating maternal equity as a priority through leadership. And in order to do that at times, what we've done is we want to start with making sure that everyone understands this critical history and that they see the importance of spreading that conversation across their group. So we'll start with leaders of healthcare systems, leaders of nursing units, and making sure that they then invite their staff to conversations and trainings. One of the trainings we used was called Speak Up Against Racism through the Institute for Perinatal Quality Improvement, and it is an 8-hour training. So it's both asynchronous and synchronous components so that some of that conversation can happen, because I really want to just highlight and lift up, again, Dr. Bonaparte saying, this conversation cannot just happen in a vacuum. It has to happen in community and with others. And that's something that we're doing too with these maternal equity bundles to ensure that healthcare teams have those kinds of conversations. I will want to say something that probably isn't said very often. People find it uncomfortable. Maybe that is said often, but people find it uncomfortable. It doesn't mean that we don't need to keep having these conversations. Change can be uncomfortable.
Yes, yes. And I just want to add something to that. First, I'd just like to start with what you just said, Dr. Robertson Meadows, is that it's uncomfortable, but it's more uncomfortable to have a mother die unnecessarily. because the impact, and I've seen that firsthand, the impact on the family, the community, just anyone who had any contact with that woman. So I don't care if you're uncomfortable, if it could prevent someone from dying, then we need to talk about it. And Dr. Bonaparte, I just have to tell you, you really just hit the core of what is wrong in our healthcare system and even in our health education. Any healthcare professional, even if you just want to work in administration, you need to know that history. And that's American history. It's not Black history, it's not Black female history, it's all of our histories. And midwifery, just imagine that during slavery, it was safer for us to have a baby. During the 1940s, when you could even go to a hospital, it was safer. And when we transitioned from the home to the hospital, and people always say, well, the hospital is safer. It can be safe, but it's not safe for everyone. So when we transitioned from the home to the hospital, we lost our sense of community. We lost a healthcare provider who knew and understood the context of the times and knew how to, what we now call social determinants of health. They knew and understood that, and they worked within that to keep us safe. But they were told, you can't go to the hospital with these women because you're harming them. And even within that history, midwives, when you look at medical text, medical journals, even the American Journal of Nursing, those very early journals from the 1900s that are all available online, they would say that Black midwives were superstitious, that we didn't wash our hands, we were ignorant. But then in the same journals, they would say how midwives had better health outcomes than them, that we interfered. There's one article where a doctor, white doctor, presented at Tuskegee University Nurse Midwifery Program, the first program for Black nurses to be trained to become midwives. He even said, we interfere too much. How does a woman have, for her 21st pregnancy, she had normal vaginal births, but for that 21st one, she had a C-section. And even states in there, it was because for us to learn. So it's in our own, it's all in our faces. But at that time, we didn't have access to that. But now we do. So there's no excuse to why you can't know this history. And it has to be embedded throughout. In nursing, I can't speak for medicine. In nursing, there are textbooks that were published 2020 that still say Black women and Hispanic women exaggerate their pain. And I'm like, that still is still there. And that Black is a risk factor. And when we have students citing that work, it's like we're perpetuating it. And all of this originated from slavery, but it's still alive and well. So I just want to share that because this history is so foundational that when you learn this history, it lets us know we have to do something different. We can't say, okay, diversity and equity, or we can't say, okay, now we're going to be anti-racist, but we're still teaching the same material. We're not going to move forward at all. And who's the ones that suffer? Those of us who came into a system that was separate and unequal at that time and still is.
Definitely. Thank you so much. And Dr. Canty, Lucinda's House is a powerful example of grassroots advocacy tackling Black maternal mortality. From your work, can you share some success stories that demonstrate the impact of community-based solutions?
Yeah, so Lucinda's House started out of my research. It started because I was in school working on my PhD, and I couldn't understand why Black women were dying. First, I didn't understand why anyone was dying in the United States. We were supposed to have the best healthcare in the world. Not only so I couldn't understand that. And so when I would ask, and I would even look in the literature, it said that we were poor, that we were uneducated, that we showed up late for care. And I said that doesn't make sense because I took care of women who showed up late and still had a healthy pregnancy, or who came to every single appointment and there could be issues that arise. So I couldn't understand. So I said, when I looked at the literature, nobody was talking to Black women. So I talked to women who experienced severe complications during childbirth or postpartum. And what I found was that there was a need for health education. There was a need to have their mental health supported, that they would even go through these situations and no one asked, even just, how are you doing? What do you think about what happened? And the other part was that they wanted relationships with their healthcare provider. They want to feel safe in that care. And the alarming part for me was finding out how race was not a risk factor, but that racism was. There were women in my study who were PhD prepared, who attended every single appointment. I had women who attended appointment at conception. They started their care. I'm like, I can't see anything on the ultrasound. And it was like, they were like 4 weeks or less. And so we were showing up for care, but we were still at risk. And what I started to hear were stories of complaining of symptoms, even having severe symptoms and someone's telling them to lay down and rest. And this woman ended up having eclampsia, a woman who was feeling tired after she gave birth and was told, you just have a little angina, go home and rest. And was stopped by an OB that came in and said, we can't let you go home yet. She had cardiomyopathy. They told her if her heart didn't improve in 3 months, she was going to need a transplant. And her first thing was, who's going to give this Black woman a transplant? But she ended up, and she was 28, I forgot to mention that, walked every day. So there was some uncertainty about how did she get to this point. But I share those because that's what I used to build Lucinda's house. And for me as a midwife, I didn't even realize I was steeped in this system that I didn't even know and I didn't even understand. So listening to Black women, hearing their stories was something that woke me up. And it really helped me see that I could not provide the care that I wanted, that I want to even to this day in our current healthcare system. So Lucinda's house was a way to get out of the system and do things that I felt was right within the community. So I do health education one-to-one. I talk with women, and I have women, all socioeconomic backgrounds, that come to me in distress saying, this was happening, nobody's listening to me. I even had someone recently who was like in distress, and she's only 6 weeks pregnant. And I said, you cannot go through your pregnancy like this. So let's just start to break things down. And I have to also say her provider was focusing on the negative complications that could happen and not looking at where she was right now. So we backed up, and I'm going to even be honest, this is a brown-skinned woman. I couldn't even see her color. She was so distressed. Talked with her, met with her 1 week later. It was night and day. She was comfortable with who she was. She was prepared when she went in for care. She let her doctor know, look, I'm a Black woman. If I have a question, I need somebody to help me. And her provider said, okay. They didn't argue with her. They were like, okay. And someone who was 6 weeks, that was told, we're going to see you in 6 weeks. She was like, anything could happen within that. So they gave her an appointment the next week. And they continued, they say, we're going to spread out your appointments, but if you need something, contact us. But just seeing the comfort in her to be able to feel like she's supported. And one thing that I love about Lucinda's house is it just brings people together. And when I have women, I did a focus group on preeclampsia and hypertension and pregnancy. And to hear the women feel comfortable in sharing their stories and realizing that they're not alone. And not all the stories are negative. Women were also showing how their providers showed up. And I see Dr. Cohen, so I'll just wrap up with this. There's a woman who, her provider was an older white male. She had a miscarriage, she's pregnant again. She said when before he left the room, he said, do you have any questions? She was so overwhelmed, she didn't know what to ask. So he said, I'm going to sit with you right here. He sat with her that she was able to decrease her anxiety. She had questions. Then before he started to still leave, what can I do for you right now? And she said, no one has ever asked me that. And again, overwhelmed, he said, I'm going to sit here for a few minutes because I know you need something from me. So we can provide the care that our patients need. We just have to show up for them. So I'll stop there. Thank you.
Awesome. We have with us Dr. Cohen, again, director for the CDC, and she's going to talk about the Hear Her campaign.
Hi, everyone. Good morning. And I'm sorry I'm running late today. My morning blew up on me and here we are. But I wanted to join, we've been doing a number of events to highlight Black maternal health week here. I was in person in Atlanta last week with all of the folks who run our maternal mortality reviews, which are the way in which we get really critical information that informs how we can all make sure that we are prioritizing how to keep moms healthy and save lives during pregnancy. This is a top issue to me personally, top issue for CDC, and wanted to make sure you knew how grateful I was for everyone's work on this. It is unfortunate that we are losing moms in pregnancy. It is absolutely unacceptable, and the disparity in it is really not just heartbreaking, but it should be unacceptable to all of us, and we are working hard to change that. And I think we need to continue to learn more and more. And sadly, 80% of those deaths are preventable, and that's what our reviews show. Whether that, that we are noticing that we have to pay attention, particularly to mental health, and making sure that we are connecting with moms about their mental health, both during pregnancy and after, making sure that we are I love that we are focusing today on listening to moms. They know their own body. They know when things are wrong, and we need to pay attention to those. I'll just say personally, my sister-in-law had a baby over the weekend, 6 weeks early. And she went to, she went to the hospital with having some pain, and they, they took great care. I want to say she got great care, but I was thinking about the fact that it was maternal health week, and that this happened in my family this week, right? So it's every family that folks are. We know that pregnancy can really challenge a person's body, and we need to make sure we're watching out for everyone and their health. So thank you for doing all of the work that you are doing. Just know it's a priority to us. It's a priority to me. We can do better. It's data that's going to help us there, but we can't collect that data if we're not listening, right? If we are not listening to folks' stories and listening to moms who know their bodies and know when something isn't right, even if maybe it's not showing up yet on some of our tests, right? How do we get to a place where we are listening to what folks are going through and really paying attention, because symptoms can present differently in different bodies and in different ways. And so just having that raised level of sensitivity, I just love that the CDC team is focusing on this campaign, Her Story. I think that is so important. What we're seeing is that kind of folks not listening to women happens regardless of income, regardless of education status, regardless. But we know it happens more for women who are Black, for women who are Hispanic. And so we need to make sure we're sensitizing everyone to make sure that we are understanding these issues. So thank you for all you are doing, Danielle and Lucinda and Audra, and you have the best right here going on. So thank you for everything that you are doing. Just know that we're really trying to pull every lever we can to make progress here. So thank you, and appreciate all of your efforts.
Thank you, Dr. Cohen. Oh, okay, there we go. All right, so I'm going to actually go back to Dr. Canty. I have one more question for you. So in your opinion, how can we bridge the gap between successful grassroots initiatives and broader policy change? So for those like myself who are trying to do the work, we, created LLCs, we created business, and we were trying to, get at this root cause. How can we have a bigger impact in terms of making these larger changes that we want to see on a national level?
Yes, and I love your question. And one thing with Lucinda's house is that I work in the community. I also work with doulas who are doing their own thing, because I even feel especially for Black doulas, we can't exist in our systems. We get lost. So a lot of doulas work on their own. The issue that I see is that a lot of times we don't have the financial support that we need to be able to go into the communities. A lot of what I do is reliant on donations. I did receive a grant to help me get started, and then I have donations, and I also do my own contributions. And the reason that I say that that's so important is because when I go into communities, if I'm talking to a mom who is having challenges with getting what she needs for just to basically take care of herself and her children, I can't talk to her about, well, when you go to the doctor, you got to get them to listen to you. I have to be able to go in with resources so that we can take care of those needs so that they can be in a position to advocate for themselves. Because what I use to go to politicians, to do my manuscripts, my presentations, all of that comes from the people that I work with. I'm a Black woman. I don't go into any Black community, even the Black community that I'm from, without talking to the people who are there. But I can't go in and just keep taking and taking and taking, and then go back to my university and write a paper and then say, oh, look, I need tenure because I did all of this work. For me, it's more than that. I feel like no one should be dying during childbirth. No one should be struggling. If you're a provider or a doula, lactation consultant, you should not be struggling to make ends meet so that you could provide the care your community needs. So that's why I say we need that support, because everything, even what I'm talking about today, comes from those that I work with. They're the ones that tell me their stories. They tell me how they go in. And I thought my water broke. I told the person at the front desk in the emergency department, and they told me to go have a seat. So I'm sitting there as my fluid continues to leak. And then when I go in and they realize I was telling the truth, now everybody wants to run around and help me. So I bring those stories to those that I educate, whether they're nursing students, OBs. I was even at Grand Rounds for attendings. I share those stories because I'm sure that sometimes they see it, but sometimes they don't understand how racism sits in that. And they don't understand how that could have been prevented. And I also want to make sure they understand that our communities know we're not all receiving equal care when we go in. And so I bring these stories. When I talk to politicians, those who are making important decisions about our care, I want them to know this is how it looks. There's people who don't even understand that we're in a maternal health crisis, and they don't understand the severity of what's happening and how so many small things can be done to prevent it. But again, I work within the system, but I also work outside of the system. So I'm able to interpret both and say, this is how it shows up. So when someone says to me, oh, these midwives, they want to do births at the home and I'm scared, what they're doing in the home. I say, well, do you look at what's happening in the hospital? Let me tell you what's happening in the hospital. So I'm able to do that. But again, I can't do that without the support of the community. So we do need financial support. We need spaces, even spaces like this, where we can speak and say what's happening and know that people are going to hopefully go back and do something differently. And sometimes when I present, I just want people to feel, because sometimes if you don't feel, then you're not going to change. So I want them to say, and I also just even want to back up. I don't want people to say, oh, that's them over there. Those are those providers. Those are those nurses or those doctors. I want people to realize we're all a part of this system. And there's something that we can do where we're at. And it's a simple ask. Even if you're in a space and you're like, I don't feel right about what happens, you don't have to go start arguing with everybody, but just saying that can make people look, especially if you're in a leadership role or if you're someone on the front lines. Because I always say our experiences and what we see in front of us, no one can dispute that. People try, especially if you're from the Black community, they try to discard our history. They try to discard our experiences. But for me, our experiences are rich and just as important as anyone else's. But I strongly feel that the communities that we work in they know what the issues are. You can go into any community and say, what's wrong? And they'll tell you. And then you say, what do you need? They will tell you. The harder part comes in when those structural things are there. And that's one of the things I see for me that's important with being in the community is we name those structures. So how do we collectively as a community address them? So again, it's just having the support to be able to do that.
I really appreciate that. Okay. So my final two questions are for Dr. Meadows. Dr. Meadows, your experience with policy development within large institutions is invaluable. I feel like as a provider, especially if you're a new one, a newly independent provider, it can feel like you are the low man on the totem pole and you don't have or you can't have influence in terms of how your labor and delivery unit is run or your outpatient clinic is run. How can healthcare providers, especially again, those new ones, work within their institutions to create and promote policies that improve Black maternal health?
Yeah, thank you for your question. I just want to even pause and honor the conversation we're having. It's so powerful and so wonderful to have this discussion. I'm really just sort of beaming with energy around how we're having this conversation. And I want to make some connections for the audience as well as we continue. Um, at this stage, for me, I'm going to use some words that I really want to make sure people leave this conversation with, that I'm going to be repeating from some of the other panelists, just to make sure that we really push that message forward. And one of the words that I want to, or phrase I want to bring up is that we are in a maternal health crisis. I think that's really a key statement, Dr. Canty. Thank you for saying that. And Dr. Wright-Terrell, this is going to all come back to your question and answering it. And we're going to take a little bit of a journey in doing so. And I use the word journey particularly because how we got here, as Dr. Bonaparte opened up, has been a long journey. And it's going to take a journey for us to get out of this scenario in the medical care system. The reality is many women that give birth and many birthing individuals, excuse me, that do give birth in hospital systems. And there's issues around healthcare financing and policy and legislation that prevent us from having more birth centers, which would be a real beautiful bonus for many of us giving birth in this country. In our healthcare systems, and I'm going to really lean in on the word system, our systems are a problem. They are failing mothers. They are failing birthing individuals. They are failing people. It's not unique to this topic, maternal health, that we see health inequities across the United States. There are health inequities that disproportionately affect African American individuals across a number of health areas. And so with that, we see where the system continues to fail individuals. And we know that. We understand that we have inherited, we didn't build this space, we've inherited a space that is failing others. And there are tools and systems we can put in place and work that we can do to fix this system. And that is the challenge. Some of the things that we need to do is, one, we'd already discussed knowing our history. And I think that's really important. Another piece of the history that I'd like to add on is the issue related to the 1910 Flexner Report that really changed the direction of medical education and discredited a number of individuals that were giving magnificent care in the communities, but then were undermined by the words of that report. And that's what pushed us in the direction of the biomedical model. I mean, definitely with a lot of things, there are pros and cons, and some of the pros around medical education have not been sufficient to undo the cons that Flexner report brought about. So that's really important that we understand that within the Flexner report, within the work that came out of that, there are now maternal inequity or health inequities and maternal inequities that really need to be reckoned with. And that was discussed also years ago in 2002 with a publication of the Institute of Medicine. There was a report called Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare. And that report examined disparities in healthcare access, quality, outcomes across many different groups, and really focused in on systemic factors like institutional racism and socioeconomic disparities and those kinds of topics. And so there's still lots of work to be done. Something I really want to highlight in that history, and then I'll move on a little bit to systems, is in that history, we understand that the definition of quality healthcare includes equitable healthcare. There is no quality without equity. And so in order for us to reach equity, in order for us to have a healthcare system that provides individuals with what they need, specific to ensuring that they get the health benefits that they can have to get their best experience or optimal experience of healthcare, we have to be able to look at our systems and understand what our systems are doing to provide for some. And I would say that we have really in this country, we've done this with our maternal equity bundles, these checklists I talked about earlier. What we need to do is ensure that everyone starts to look at each population served when we look at our outcomes and not just the population served. That's been our challenge. In the past, when we look at data that comes out of hospital systems, and data is one of the first ways within the healthcare systems that change occurs. We pull out the information and show it. And when people look at that data and say, that doesn't look like us, that doesn't look good, we want to do something about it, that really starts to get people moving towards action. When we show data on inequities, something Dr. Canty said earlier, people start to point in different directions and say, that's that person's issue and that's that person's issue. And then they find themselves in inertia and not doing anything. And so we've got to shove everyone out of inertia. and inspire everyone to move forward and motivate everyone forward through systems change. So systems change is imperative. If we don't change the system's going to keep producing the same poor outcomes that we've been seeing, because we can't keep doing the same things and expecting a different outcome. And we know what that definition brings us toward: insanity. So that history lets us know from years ago that medical education has led us in a path that has eliminated the ability to see everyone in the right way. We know that the Institute of Medicine for years, the United States has been saying, we've got to change our systems. And now here we are 22 years later, and our systems are still performing poorly. To what Dr. Cohen said, yes, data shows that in the maternal health world, our numbers continue to rise in terms of maternal death and illness. That is despicable, because in other countries, those numbers are going down. We're still seeing, when the next set of data that comes out from the CDC arises, we're going to still see ourselves on the way up. And that has to change. And with being able to change the data, we have to look at equity as well. We have to look at that data by demographics, by gender identity, by race, by ethnicity, by age. Because when we look at this maternal inequity data, some of the greatest or the most negative outcomes are those among those who are older in maternal health. And we need to understand what that means for health and chronic conditions and care, et cetera. So there's a lot to be done with thinking about our system, addressing system equity, and addressing data. And then I want to move into teams. We've talked a lot about community. We can't get this work done without creating a healthcare team that supports the whole individual. One key member of that team is the individual who's pregnant and giving birth. And that hasn't always been the case. That speaks to what we're saying about not being heard, not being seen, not being valued in your own care experience. That has to look very different in our healthcare systems. And when we do that, when we want to make sure that we're working with a team, we need to respect and ensure that everyone can work to the top of their license and their training. I'm a physician. I don't do what nurses do as well as what nurses do, right? And then there are social workers in our system. And then there are anesthesiologists and other nurse anesthetists. And there are people within the system that if we work together and we respect and allow each other to all be a part of that team and know that what we bring is unique, important, and a skill that helps the individual, and that individuals is the expert in their own care and the expert of what they need and what they would like to see, then we can really do a great job. In order to get there, we have to be in community with our community. We have to hear the voice of the community, know what's happening, have relationships with organizations like what Dr. Canty has started. We have to continue to do that kind of work. That means taking a different approach, having a different lens in the way we do business in the healthcare systems. So in order to change these healthcare systems, we also have to change our healthcare system culture. We have to all decide that that's who we are and that's who we want to be and uplift that. So coming to what you'd asked, Dr. Wright-Terrell, about what can folks do, when we put in place what we call safety bundles, there is a national program called AIM, the Alliance for Innovation in Maternal Health, that works to address health inequities, the maternal health crises based on what are the leading causes of maternal death in the United States. So there are safety bundles on obstetric hemorrhage, severe hypertension, blood clots, and many others. And these are just simply checklists. We have to hold each other in healthcare systems accountable by putting these checklists in place, by looking at the data by all populations and not just the population, because many smaller groups of the population get washed out by the larger numbers. So we want to look at everyone that's being cared for. We want to make sure we're doing a good job for everyone. I often tell my students that when a person leaves the hospital, everyone gets a discharge summary that tells you what happened. That is equality. When you give a discharge summary in their native language, the language they speak and how they communicate, that's equity. And when we do those kinds of things, that isn't difficult. But oftentimes in the healthcare system, people will say, what is equity? What does that mean? What do we do? This is hard. It's actually not hard. We make it very simple when we put together these maternal safety bundles that focus on equity, and we make it clear. So some of the strategies include making sure leadership communicates equity as a priority and making sure they really invest in the resources and support needed to establish a culture of equity, so that we're doing these kinds of things, looking at our data, monitoring our data, surveilling our data, making sure that what we're doing, the activities and initiatives we put in place are being measured and we're holding each other accountable. Making sure that we're engaging with our community and strategic partners, that we're listening to patients and members of the community. We invite all of what Dr. Canty described into our clinical spaces when we have equity committees and we create governance to think about these things. But that governance isn't complete if we don't have members of the community as part of that, and making sure that we create a very smooth path to invite people in. It's like when we have a party. We don't want to invite people, but then make it difficult for you to park and show up and come in or eat, right? And we need to do that even in our healthcare systems. We're having babies on our labor unit. We're creating families. So we need to make sure we're thinking about it in that way. We also want to make sure we incorporate those best practices. And to do that, everyone can be involved. So that's a long journey to the answer to what I would say to your question, to make sure that even newcomers, mid-level providers, what's some call, because I always saw myself as someone who led from the middle in the spaces and places where I was. We all can have a role. Every one of us are important, including the patient. And when we're following these checklists of items, we're just ensuring that we're giving optimal care, the most recent care, the best practices, and that everyone is part of it. Simple things we would put into a checklist is after a maternal morbid event, if there was a maternal hemorrhage, make sure it's written down that someone should go speak to the partner in the family. Don't let that be something that we remember later on, right? Those kinds of things that really take into account everything we do and everything we're doing to support an individual and their family and people that are working with us. So checklists are important to me. I really like them. I think it fits my personality. At the same time, I like it because it allows us to know what we're doing. We're all speaking the same language. We're all going in the same direction. We can all agree on our goals, but we can also bring everybody to the table and involve everyone in making sure that we're working together to accomplish what we know we can accomplish. I mean, we can really optimize birth and fix our systems. I want to say this works. This is my last statement on this. Perinatal quality works. It really does. We've seen where people have put in place checklists, and we've seen maternal morbidity, rates of hemorrhage go down. We've seen gaps between Black and white outcomes close, and we've seen that be sustained. And so when we do that in the healthcare system, and let me be really clear, that is only one part of this, but it is just the space that people come in through those doors. What we want to do ultimately is make sure that hospitals live up to the name hospital, that people should be able to walk through doors and expect a level of quality and safety that all of us would expect across the country at any hospital. There shouldn't be variations. That shouldn't be allowed, right? We should be able to do the work that allows everybody to walk through any doors and get what they need, or be, transferred to where they need to be, or those kinds of things. But that should be a part of our system that serves and supports individuals. And so if we keep doing this work, I think all of us can be a part of it and be really successful.
Thank you so much. I cannot wait to take my AIM checklist to my new place of work and just disrupt everything. My last question to you is how can we hold the health system accountable? We have this new tool, we have the checklist. We say this is what we need to do. We've identified the need through our conversations with our patients and with other providers. We validated the patient experience. We provided the tool. How do we keep the progress going forward? How do we ensure that the plan has been implemented effectively and we're tracking change appropriately?
Thank you for that question. Yeah, within these healthcare safety bundles, the way we implement it is through something called improvement science. So there is a way we do things. And one of the key features of that is that we have measures in place. And so really having these measures not only in place, but transparent and visible to everyone, and then being able to report on how we're doing and making that transparent to everyone so that people know that we're, one, doing the work, that we're monitoring how we're doing it. It's also a way to motivate everybody, because when we're being successful, we get excited. We want to keep doing it. We want to keep getting better. That's what we want to see happening. No one wants to really sit in the shame of we're failing birthing individuals across this country. So the more we can do better work, the more we can really encourage, motivate, and inspire others to come to the table and keep doing that work. But those measures are really important. That's how we hold ourselves accountable. That's how we know we've met our goals. That's how we know our goals are realistic and our goals are achievable and our goals are, and when I say realistic, people often think the opposite direction. I'm not saying realistic like our goal should be 75% versus 85%. I'm saying our goal should be 100%. why should we not expect perfection here? We can do really well at a number of things. And so we want to make sure that those measures are how we hold ourselves accountable, and that everybody sees where we are in our journey in trying to improve these systems of care.
Thank you so much. So what I would like to do, if anyone feels brave enough, we have time for maybe 2 to 3 questions. So I want to open the floor. Feel free to share your experiences. Again, ask a specific question to one of our panelists. And yeah, this is the time for engagement.
Can I also comment on a comment in the chat? Someone did say that funding should be available for implementation of AIM bundles in all birthing hospitals. I agree with that. I want to uplift that. I do want to say that Dr. Cohen was on. The CDC is the funder for most of the work that happens at state perinatal quality collaboratives to fund implementation of these AIM safety bundles. It does not require you to be a member of a PQC to do that. Hospitals can do it on their own. But I do agree that continued funding should be there, that there should be more of an integrated system of rewarding and supporting hospitals for participation in doing this kind of work. So thank you for that comment in the chat.
While you're waiting for questions, I do want to elaborate on something that you said, Dr. Robertson Meadows. Two just really powerful things, and one is having the team work together. And when I think about delivering, and there were complications, when I had a nurse that was supportive, when I had an OB that was supportive, it was like we were together, able to just make sure that the mom and baby were okay. And I'm just even getting chills thinking about it. When a case where a woman even had she had an abruption. Her placenta was separating. And having the nurse say, I'm concerned about this patient. You know, me saying, I think that this is an abruption, and having the OB say, let's get ready for cesarean. And she did have an abruption, but and she was 32 weeks. And the mom and baby were okay. But it's because we worked together as a team. And even the amount of time that we were able to do this, it was, people even could not even believe it. From assessment to the delivery, but it was because we all worked together as a team. And I just want to say with the AIM bundles is that it holds people accountable, because when you're looking at inequities, especially racism, it shows that some people are receiving the standards of care and some are not. Somebody with a headache being sent home and no blood pressure taken. Then when she comes back, she's severely preeclamptic. And they, oh, how did this happen? So I'm just saying it's a way to hold people accountable. And I actually go out of my textbook and I use the bundles to help to show this is how care looks and this is why these certain things are done. So it's an important teaching tool as well for students.
I really appreciate you saying that. You're so right. One of the greatest reasons for the inequities and the disparities is time. That was exactly right. Like being able to be prepared, ready, and responsive in a timely fashion saves lives, minimizes morbidity or illness or sickness that could be related to pregnancy experiences. That is so key. So thank you for saying that.
I just wanted to pop in really quickly and again, just say this is just a wonderful space to be in. I saw that there's a few questions that dropped into the theme. So the first question, I think if I'm looking at it correctly, is there a pamphlet or guide to give to OBGYNs to give out to every woman of childbearing potential, what to look for, expect during pregnancy? And so I really appreciate this. There are materials. I think the question then becomes are people actually giving it out, right? And do they know? So I just wanted to slide that part in. I think the other thing is there's a number of different foundations. Like I'm based here in California, so there's the California Healthcare Foundation, and I worked with them and also with Consumer Reports to create a series. It was an animated series that kind of talked about these are questions to kind of think about in order to potentially avoid having a C-section, for example, right? An unnecessary C-section. So again, I do think that there's information that's available. I think the thing becomes is where can people get that information from, and are people actually withholding that information, or do they not even know?
I would also like to uphold the A1 stands for, and I'm going to pull it up so I don't miss the word, the Association on Women's Health Obstetric Neonatal Nurses. They have a post-birth warning sign education program. If you go to their webpage, There are lots of flyers and pamphlets. Many nurses are trained to give these warning signs at discharge. That's also part of these safety bundle checklists of best practices of what to do. So I think that's a really great pamphlet for people to have, because I think the important thing is to first, I want to say, stay positive, right? Having a baby is a beautiful experience. It's wonderful. Pregnancy is a beautiful experience. It can be wonderful. So I want people to always live in that and not live in the fear of what could go wrong, but just be prepared to know what a warning sign looks like and what that is. And so the A1 post-birth warning signs, I think, is a really great pamphlet or some source of information for people to understand. Here are the directions that we need to come back to our healthcare systems and have these conversations. But to what all we're saying, we want to make sure that people feel heard. And so sometimes even just walking in with that printed out may be helping you to speak the language of the other person, so they won't dismiss or unhear what you're saying, and pointing out, this is what I'm experiencing. I really would like to seek help for this. Getting in touch with your provider. So I think that's a really good statement and comment to think about, having a pamphlet or a guide to give out. And that's only for post-birth. There's lots of others pre-birth. But for post-birth, I think that's a really critical period for us to focus in on.
There's also, there's also patient advocate groups that exist within hospital settings too. I saw the latter part of the person said sometimes people will stick with a provider even if they feel like they're not being served. And so I do think that thinking about and leaning into, if you are having birth in a clinical center, for example, is reaching out to patient advocate groups to also assist you in potentially moving to a different provider and having support. I also recommend, if you have the possibility and the financial means, is having a doula as well as another person who can function as an interlocutor for you.
Amazing. One of the questions asked, can and should community be made aware of how a hospital is performing using bundles, checklists by hospital, having a designation similar to baby friendly?
Absolutely.
Yes, absolutely, absolutely. I'm so sorry, Dr. Meadows. I'm just excited about this
Sure.
because in California, we have the CMQCC, which is based in Northern California, and it actually has that listing of information. They've regularly been doing data points and research points and things of that sort to be able to determine for people, these are the hospitals that are performing really well. These are the hospitals that are not performing well. There's also the Earth app that I wanted to mention by Kimberly Kimberly Seals, in which she kind of also discusses with people like, these are providers and these are some of the places that they're attached to that also assist in people making those decisions. Sorry about that, Dr. Meadows. I didn't mean to
Oh,
cut you.
no, don't apologize. I'll add on too. So we, CMQCC, one of the PQCs is the state of California's PQC. We talked about Massachusetts, the work I did there, our team did there. There are other states that have it. Absolutely. Your state perinatal quality collaborative should also be reporting that. Your hospital system should. We need to get to a point where, yes, absolutely. I mean, we live in a capitalistic country. People should be advertising and telling us how they're doing, because you do pay for this care through health insurance or out of pocket. So yes, that should be out there, how people are performing and what you're going to get from this care that you're getting ready to embark upon. We try to do that well with PQCs. We're improving on it. We want to keep getting better all the time. I also wanted to say, to your point about Kimberly Seals, I hope she's got a team member listening, because it'd be great for us to keep participating and communicating with Kimberly Seals. So if Earth app could say, this hospital implements safety bundles, that gives you that information right there. You know what they're trying to do. You know that they're working on trying to make improvements. And the way to get toward pushing for these kinds of things to happen is through leadership. We have noticed, this is the research that I do. So what are some of the findings we're coming out with is that in order to get this work to get started, in order to get the motivation moving forward, it has to start with leadership. Community advocacy to the leaders of healthcare systems can really be powerful in moving that work forward.
Yeah, and we have to make sure that hospitals are being very transparent with some of their health outcomes. And I just also want to make sure what's not lost is that we can have statistics on the number of cesareans. We can have the statistics on vaginal births, but there's not often a lot that people can read about the experiences of care other than the Earth app. But I'm just saying, like, you could have a healthy mom, healthy baby, but her experience, she could have been traumatized throughout. She could have fought her way to get to have the birth that she wanted to have, or she could have fought and had a cesarean. I was in something recently where mom was like, they kept telling me to do a cesarean. I didn't want to, but to get them to leave me alone, I said yes. But there are some stories that aren't captured. And then we start to hear patterns, though, when people start to talk about, well, that happened to me with that provider. And it's the same provider working there for years. And it's scary when you see someone who had a baby 10 years ago and someone just had a baby are sharing the same story, and a very negative story. So I think that we have to have ways where we can get that information to really not only make the informed decisions for the consumer, but also for the hospitals to be held accountable. Why is this person still here if they cause harm? So we need to really expose those things. And I feel the Earth app is really the closest thing that we have right now as far as the experience of care.
And Dr. Canty, I want to, as well, like Dr. Bonaparte said, I'm excited. So I want to jump in on that too and just quickly say, there are folks who have put together what we call validated tools, surveys to look at experiences and outcomes. And I'm not talking about patient satisfaction, like you got an email from your hospital saying I was satisfied with my care or not. We're talking about really getting at the heart of dignity, respect, autonomy, et cetera. So making sure that people have respectful care. Part of our equity bundles, we've asked teams to, as a governance, put an infrastructure to ask those questions and to have what's called a PRIM, a patient reported experience measure. What is their experience? It's not, you're right, enough to just have a good outcome. We want to have a good outcome and a good experience because we can give both. We can't give both. So we can keep working on that, because if a person, let's say you're someone in the audience that actually needed a C-section to save for a safety standpoint, it shouldn't feel like it was a crowbar experience for you, right? It should feel like it was something that across the entire time you were in communication with your team and that we were all coming to the same decision together. And that shared decision making is a part of what's happening in your care. And people can give us that information through those patient report experience measures, so we can take that back to leadership to say, here are the resources you need. Here's what we need to be able to do for training. Here's how we need to hold ourselves accountable in order to make sure that happens. That has to be a part of the best practices, not just, what's the right clinical care to offer, but the right way to offer clinical care so that we're having those kinds of experiences too.
I see that Dr. Bonaparte, we were both thinking the same thing at the same time. We put Dr. Karen Scott's work.
Yes.
Very important work that she's doing as well.
I think we have time to get to one more question. This was in the Q&A. So the person acknowledges that this is a powerful discussion. I agree. You all have mentioned care team collaborations and accountability between caregivers. I wonder if part of the problem could be a lack of mutual respect between providers, between physicians and nurses, nurses and midwives, doulas. If you have encountered this issue, how do you address it?
That's a tough one, but I'll start with that. And I'm only sharing my experience as a Black nurse and a Black midwife, is that being Black has created challenges for me that are sometimes supported by the system. And I can just share really quickly, even a story where I was delivering a baby and the nurse was so ridiculous that the patient is like, what's wrong with her? And I was like, I can't focus on her. Let's focus on you. You're the important person. But we also do need to address, I know we don't have the space for this, but what happens within professions and nursing. And I'll actually put in the chat a documentary that will be coming out addressing racism in nursing. But we really need to talk about that. And and experiences of racism starts in our schools, nursing, medical school, and it kind of trickles because a lot of times it's not addressed. Is it within our healthcare system? So as a provider, when you're trying to advocate or do something for your patient and you're questioned and you have more knowledge than the person who's questioning you, and it's the patients that are harmed. So that creates a breakdown of the team. And just as I showed an experience where I have a support from the nurse and the provider, the OB, but there are experiences where I was challenged when I really honestly should not have been challenged. And I can even say that because what I believe was happening to the patient was really happening to the patient. And no one ever came back and said, oh, you were right, or sorry about my behavior. And when they realized something was really going on, it was like I still didn't even exist. But that's a tough question. So I'll leave to see what others have to say.
Yeah, I'd like to comment on that too. I think it's a really great question. I put in the chat a program called Speak Up Against Racism, which I think is an important now. Your question wasn't about racism in particular, but what you're talking about is